And just before we get into the presentation, I'll share just a little bit about Migraine and Headache Australia. You may have joined us just in the most recent week, or you may have been part of our community for the last few years. But really, we have three goals as part of our mission. One is to provide trustworthy and reliable information, which is what tonight is going to be all about. We also fund research, and so over the last, I think, 11 years, we've funded 8 different research projects into headache or migraine of some type, and we try to do that every year. We have an independent scientific medical review that evaluates submissions on their own merit. And finally, we advocate and support for people living with headache disease, and we'll talk a little bit about that a little bit later on. Some of the things that we've done just this year are shown here, and each night I'll mention just one because I don't want to get in the way of the presentation from our expert. So I'll quickly just mention one that we've got, which is the Commit to Care campaign, which is a campaign that's been running throughout the month of September and through Migraine Headache Awareness Week. And it's about encouraging fellow Australians and some of the internationals who are on the call to reestablish self-care routines, which we know can be so helpful in managing chronic headache and migraine disorders. Now, we're not pretending this is the cure, but doing these types of things that we know are good for the brain, good for our health, can really complement the treatment that we might be prescribed from a doctor. And so it's really about taking small steps, taking action, and turning the corner in your health condition. So thank you to Hydrolite, who are supporting this campaign over September for us. All right, so are you in the right place? Do you have headache or migraine? Are you a parent or a partner or a caregiver? Do you want to connect with someone else like yourself, or do you want to ask the expert questions? You're in the right place if you tick any of these boxes. And if you want to ask a question, let's show you how to do that. So this is the screen. You're probably seeing something similar to this right now. In the bottom right-hand corner, you can see the Q&A mode. There's also, there might be a chat mode where you can send questions through to our admin. So those are all options that you can communicate. And so we've got a moderator who's going to be on tonight and answering questions. Her name is Anik, and she'll be able to help you out during the presentation, and we'll also be collecting those questions. So make sure you mark them as Q&A mode. Make sure you use Q&A mode when you begin, so that she sees that it's a question you would like answered at the end of the presentation. So let's get to our speaker tonight, Dr. Bronwyn Jenkins. Many of you may recognize her from last year's Migraine and Headache Awareness Week. She was a very popular speaker, and we've brought her back. She is the president-elect of the Australian and New Zealand Headache Society, which is the leading, medical body for migraine and headache in the region. And she's also got several other memberships with the International Headache Society and other groups elsewhere internationally. She's presented at the International Headache Society. She plays a leadership role in the Headache Master School program, and is obviously very involved with her own public and private practices that she's involved in. So without further ado, we will kick off with our presentation.
Hi, everyone. Great to be here, and I hope you're enjoying Headache Week. It's a shame we can't meet up in real life, but hopefully we'll get to that as soon as we can. So this is my top tips for triggers. So triggers are a measurable endogenous, so in the body, or exogenous factor with an increased probability of headache over a defined time period, such as 2 or even up to 3 days after the trigger. The most common is stress, hormones. There can be missed meals, weather, sleep disturbance, odours, alcohol, heat, foods as the most common triggers in the earlier studies. But there's wide individual variation in the relevance of trigger factors. So what is most relevant to your best friend or your partner might not be as relevant to you. So I think it's worth knowing all these things so that you're armed with information that might be of use to you. The other thing to note is that most people have a combination of triggers rather than a single causal trigger. So this is interesting data because it's such large numbers of 1.8 million users in Migraine Buddy, which is an app diary. And the most common was stress, followed by lack of sleep, neck pain, anxiety, weather, and dehydration in the 2021 data. Trigger information is obviously quite complex, and I think we often cut it short because of this, but it can be quite easy to provide information, and anyone who's interested in having a downloadable version of the things we'll talk about, there is the 2-page self-care for migraine handout on our Headache Society website that everyone's welcome to look at. So firstly, let's think about sleep. So sleep disruption can be a trigger for migraine, and most people listening to this will recognize that. It's got a bi-directional relationship here with migraine. So migraine will obviously disrupt the sleep, and there's an increased risk of insomnia with this disorder, with the interictal, fearfulness, all of the factors of migraine. But then insomnia will also worsen migraine. So some of our best management options is to actually help the sleep as well. Other sleep-related disorders are worth thinking about, like grinding your jaw, bruxism, and sleep apnea. So people can call themselves if they don't have a bed partner, or simply have the bed partner go to bed after them and ask whether they're snoring. Stopping breathing is less obvious usually, or grinding their teeth. And then the next logical step would be to know whether sleep interventions help. But there's been less quality and size of studies looking at this as with regards to the psychology of better sleep hygiene. So to go back to this self-care for migraine 2-page sheet, there's some good strategies about how to try and improve your sleep. So have a regular schedule, go to bed at much the same time, avoid daytime naps or caffeine after 3 p.m, alcohol worsens sleep quality, relaxation techniques or other techniques can help. And avoid screens, obviously, use the bedroom for bedtime. So moving on to probably the most popular trigger topic, diet. So I think diet is more than one thing. There's cravings, food sensitivities, and then there's the role of a healthy diet with potential anti-inflammatory and neurotransmitter stabilizing properties. So the interesting research recently has been some cravings may be premonitory symptoms. So food cravings is right there in the list, you'll see, of the stage before the headache phase. And we think that's related to hypothalamic dysfunction, whilst the sensitivity to light, so feeling like you're triggered by light, or even yawning and feeling fatigued, and therefore fatigue is a trigger, can be from the thalamic or cortical dysregulation or dopamine function. So there's probably some biology behind some of the things we appreciate as coming before the headache phase that are actually part of the headache phase rather than being the trigger for the migraine attack. So this interesting data showed that migraine attacks could be elicited in these patients, and the ones that reported sensitivity to light as a trigger actually had sensitivity to light in their premonitory phase. And those that reported snackish or food cravings as a trigger had the premonitory cravings. And those that thought that skipping meals or being hungry or starving was a trigger had the premonitory cravings with excellent statistically significant agreement, with less but still good agreement of the stress and the premonitory mood change. So there's ongoing hot debate about some of the things we perceive as triggers that obviously are more common in chronic migraine and go down once we've treated the migraine disorder clinically in my practice. And we're looking at them now as part of the migraine phase. But moving on to what if diet is triggering migraine in some individuals? Well, it is potentially modifiable. It's individual. So we always state the top food products that can be relevant: alcohols, particularly red wine, cheaper alcohols, ones with lots of preservatives, chocolate, cheese, citrus, MSG and other additives are very individual. But it's definitely true that some people know they can't get a takeaway from a certain place, but they could get it from somewhere else. If you're doing an elimination diet, this is not a food allergy. So you don't eliminate everything and every single day introduce a new food, because you won't get a clear-cut, reliable migraine like an allergic rash. So it's worth eliminating one food, I think, for several weeks at a time, and then re-entering that food. So you know that if you were better for those weeks off the food and then worse for those weeks back on the food, you then have conviction to then exclude it from your diet, because people are obviously suffering from the things they're trying to exclude as well as from the actual food sensitivity. So you want to make sure that it's worthwhile eliminating it from the diet, because it makes it very hard to just socialize normally. So on to the specific types of diets that might be helpful for migraine. The most interesting and most recent has been the omega-3 diet. So increasing the N3 fatty acids, even if they did or didn't reduce the N6 linoleic acids, was helpful in decreasing the quality of life score and improving it, the headache frequency, and also the measurable hydroxydocosahexaenoic acid. I challenge you all to say that word. So it definitely showed some benefit in the active groups of the basically omega-3 diet compared to a controlled arm, which is our gold standard for how we do the dietary trials. It decreased the monthly headache days by 4 and 2 in the two groups compared to control, which are huge changes overall in a study. Now, of course, this is not for someone who doesn't like eating fish. So you can see the table there. The reference is below on the slide for anyone who actually wants to look up the protocol. You really need to like eating these food groups if you're going to do this diet. Then there's interest in the ketogenic diet. So this is a high-fat, low-carbohydrate diet. It's felt to alter glucose transport, mitochondrial function, oxidative stress, cerebral excitability, cortical spreading, depression, inflammation, and gut microbiomes, all of which have some relevance in migraine. And we do use it in epilepsy, particularly in young refractory epileptic conditions. So it's of interest in migraine. It's quite a restrictive diet. And then there's some healthy diets. So as an example, but not the gold standard for migraine necessarily, is the MIND diet, which was used for other cognitive issues, which, as you can see from the plate of goodies around it, is essentially a healthy diet. And then there's a DASH diet borrowed from the hypertension diet group. And it's got particular salts, fiber, and protein as the primary components. And these have all been studies showing some decrease in severity and duration of migraine attacks. But I think the diet that is useful is the diet that you can sustain as long as you see a benefit at that time. So in our self-care for migraine with the Headache Society, we specify that there are specific diets, but there are simple things to do, such as not having fasting, keeping the blood sugars even. I often say low GI complex carbohydrates, and avoid the clear dietary triggers that you figured out. On to dehydration. So dehydration is a known trigger for migraine. I have some patients who come to me purely because they get worse migraine attacks when they're exercising, and this is very limiting in their life, particularly if they want to do marathons or longer bursts of activity. So conversely, we think that good hydration can reduce the migraine disability, severity, frequency, and duration. And obviously nausea and vomiting can cause dehydration, so we always target that as well. So in those that are getting sports-induced dehydration, it's really important for them to prehydrate and rehydrate if it's strenuous. And for most people, it's important to drink plenty of water, 1.5 to 2 litres a day. And acutely, if you went to emergency, one of the most important things would be the IV drip to rehydrate you. So in our self-care for migraine, you'll notice that I'm telling you about this as a wrap up each section. We suggest that most people drink a healthy amount of fluids every day, particularly if it's hot or you're exercising. So on to exercise. So we know that there's positive benefits biologically for exercise of suppressing inflammatory modulators, cytokines, stress hormones like growth hormone and cortisol. And psychologically, it improves migraine self-efficacy and the locus of control, leading to reduced migraine burden. There have been multiple studies showing multiple exercise strategies being helpful. without any single one, although higher intensity training seems to be more effective if it can be tolerated. So on a day of migraine, most people can only do low impact options. So we suggest regular exercise to reduce many forms of pain, including headache. Walking is a good low impact thing that's simple to do, and I'm sure we've been doing that a lot during the COVID lockdowns. But at the time, it may worsen symptoms, so choose the best times to do that. On to stress and anxiety then. So there's a very complex and bidirectional relationship with anxiety and depression. And there's similarly been evidence for benefit of relaxation, meditation, mindfulness, acupuncture, yoga, breathing techniques, progressive muscular relaxation, biofeedback, and cognitive behavioral therapy. So again, it's whatever's available and the best thing to resonate with that person that helps. And we've seen during the COVID outbreak that stress of sudden lifestyle changes has worsened migraine for some. So relaxation techniques is a very powerful strategy that people can learn. And I've had some patients who've had highly effective multiple preventives for many years that have finally turned the corner with the best form of mindfulness for them. And it's very individual. So we recommend relaxation for 20 to 30 minutes, 3 to 5 times a week in our handout. On to caffeine now. So the weird thing about caffeine is it's useful at the time of a migraine, but regular excess use can lead to withdrawal. So this is its analgesic properties, right? An acute higher dose is suggested to be limited to 2 days a week. There's limited evidence regarding the ideal daily dosage, but I generally recommend 1 cup of coffee. And obviously, percolated and brewed coffee has different caffeine levels than the instant coffee. When I'm asking about coffee, I ask whether it's a large, which is a double shot, or whether it's a normal. And tea has less, so you can usually get away with a little bit more tea. So you can look this up easily on the website. Caffeine. So avoid excess caffeine. More than 1 standard cup of coffee per day can worsen the headaches. So it's again a matter of doing it for long enough to see whether that reliably helps. So the next thing we should talk about is the general environment. So most of the people listening will have noticed that glare or lighting, smells or weather changes can be a trigger at times. But these are hard things to measure. There's limited studies other than animal models or specifically looking at photosensitivity from the premonitory point of view. So really it's about what we've noticed. And the working from home group found that there was some improvements and flexibility of working from home, such as being able to be less bothered by light and noise. And I would add chemical smells of being in an office environment and now being at home. And some had a better work-life balance. But we didn't notice any people worsening significantly with the worse desk setup and posture from the initial working at home. So you can see how individual it is and how it's a combination of things. So there's some good advice on the handout about workplace ergonomics, avoiding repetitive activities and having regular breaks, which is postural rest and eye breaks, is useful. Glare can be good to minimize. So if you're facing the window in the office, you might want to face away, and trying to avoid the smells that trigger you reliably. And to add to this, physical therapies are obviously of use, but not really so much in the trigger talk that we're giving today. So hormonal triggers. There's 2 big arrows on this graph showing that the estrogen starts to drop a couple of days before the menses, when you start to shed the endometrium and start bleeding. So a lot of women with migraine will experience worsened migraine attacks that are more severe, more frequent, longer lasting, and more likely to relapse, as well as being harder to treat in the 2 days before and the first 3 days of the period when that estrogen is dropping. But you really need to keep a headache diary to determine this. And it can be useful to recognize this, because if the hormones are your main trigger, we can either stabilize them with hormonal treatments like suppressing them with estrogen if you don't have aura, or use what we call mini prophylaxis, which is a regular triptan or similar to stop it becoming an untreatable migraine at those highest risk days. And then other head and neck triggers. So there's this concept that there's only one pain center in the head, and convergence of all the structures, the eyes, the sinus, the teeth, the nose, the ears, the scalp, they all converge into this one pain center. So if you have someone who has the genetic biology of being able to generate migraine, anything that's stirring that up, from a sore jaw through to a dental abscess, can worsen their migraine attacks. But we don't necessarily image the structures of the head and neck in everyone. So these are two extraordinary pictures, one of a very bad neck and one of, on the left, of very bad sinusitis. You can see the bright white in the maxillary sinus at the top of the image, and some big white dots at the back at the ethmoid sinuses too. You only do the test if it's going to change your management. Not every person with migraine needs to have their neck looked at, but obviously if you've got a surgical requirement for the neck, then we would look at the neck imaging. And it's the same for sinusitis. You would only look for it if you had symptoms of postnasal drip, nasal stuffiness. And once you'd seen that that was clear whilst the person was having their headaches, then their nasal stuffiness is more likely to be related to their migraine disorder itself rather than the cause. But do think about everything in the head and neck. And then probably a really important area to talk about in any talk for migraine is medication overuse. So as previously talked about as rebound headaches, it's usually a secondary diagnosis. So it's because of the frequency of high frequency episodic or chronic migraine that the person is actually taking too many of the analgesics, which is set at more than 5 days of codeine, but by the classic definition, 10 days of codeine, and 10 days or more of triptans, but more liberally at 15 days or more of the simple analgesics like paracetamol and non-steroidal anti-inflammatories, which we worry about much less. So chronic exposure to these acute care treatments can lead to suppression of the endogenous anti-pain or anti-nociceptive systems, and it can be indistinguishable from the primary headache disorder. So I don't think you can tell it's medication overuse, or I can tell it's medication overuse from someone's history until we've tried to stop it. But on to the next slide, the really compelling thing is that in the studies we currently have, which are limited, approximately 2/3 of patients are 50% or more better just from stopping the overused medication within that first month. It's quite complex to, how to stop it depending on which medication is being overused. So patient education, withdrawal of the overused medication, using other things instead. So I tend to mix it up and offer other simpler options to gradually be able to decrease, for instance, the codeine days, and trying to decrease the severity as well as the frequency if possible whilst in this state with preventive treatments. It's worth noting that there's really great evidence coming out that in the real world data, triptan overusers use many less triptan days once they're on a CGRP monoclonal antibody therapy if they're a responder, which makes sense because there's some post and pre-synaptic feedback there. So I think that to decrease the frequency and severity of headache attacks makes it easier to take less of the strong treatments until you've had long enough out of that vicious cycle. We usually only use inpatient infusions for those that have failed to withdraw as an outpatient successfully. But there's a high rate of relapse in the order of about 40%. So we have to just be supportive and look out for that. Then on to sort of deficiencies being a trigger and everyone's natural question about the natural supplements. So there's a big difference between correcting a deficiency and actually advising supplementation for all. So we'll talk about those two things separately. I usually do a simple blood test if I think someone might be deficient in D, B12, iron, or thyroid hormones. We should be taking care with some of these natural things because if they're fat soluble, they can accumulate, and some can be neurotoxic, such as B6. Some are no longer recommended and have been less available in Australia for some time, such as butterbur. And we have to be really careful in conception and pregnancy, and they should only be on a conception supplement at that time. So there's evidence for magnesium being helpful. There's 5 double-blind placebo randomized control trials, and it gets to level B evidence by the AAN and American Headache Society criteria. So in that main study, there was 600 milligrams a day, but in Australia, that can be limited by diarrhea unless we're getting one of the chelated forms from overseas. But we usually use 200 to 400 milligrams a day. And then there's also evidence for riboflavin. So again, there's been 11 studies that was looked at in a meta-analysis with mixed results, but we generally recommend 400 milligrams, which helped in one study, giving it, again, a level B evidence basis. It's safe and it's cheap, but it can be powder-coated and a bit disgusting in taste and can cause nausea, yellow urine and diarrhea. So I think a natural supplement doesn't come without things to tell people, and just like we explain a medication, I always explain supplements. Coenzyme Q10, it has known antioxidant, anti-inflammatory actions, yet very useful in a lot of disorders. And it's shown some improvement, but is only level C evidence basis. It's relatively expensive. So that's why the multiple supplements that come as a polypill will be more expensive. There's interest in curcumin and vitamin D. And so certainly I would replace anyone's vitamin D deficiency. And then there's obviously interest in melatonin, which is now over the counter. And there's been several randomized control, one of which I more recently looked at is comparison to amitriptyline and was non-inferior. In clinical practice, it's probably not as potent in helping the sleep as amitriptyline, but certainly it's worth trying as a natural, well-tolerated supplement that's available. So in supplements in our handout on the Headache Society website, we do suggest magnesium, riboflavin, and CoQ10. So my top tips overall are that we're all on the same page. We're all on a quest to find the cause or causes of a migraine. And I would think that it is usually multifactorial rather than one single thing that you're missing. I should add that I noticed that with increasing frequency, people are more sensitive to their triggers, which makes sense, and that a lot of that disappears when they're on more highly effective treatments, that they no longer are as easily triggered and can get away with a cheeky beer or a silly hot day. Evolving knowledge does suggest that some of the features that we've attributed to just happening just before the migraine and therefore being a trigger might be part of the premonitory or early phase of the migraine. The other thing is that potentially modifiable trigger factors are going to be really individual. So there's even rarely within a family group the same bunch of triggers for each individual. So don't dogmatically tell other people that your trigger is going to be their trigger, but it's certainly worth having all the knowledge of what things you can do to try and self-manage your migraine yourself. So I think you need all this advice to know what things you can pick and choose from that are relevant to you and also sustainable in your lifestyle. A headache diary is essential, I would say, for determining the most identifiable triggers, because migraine is always there, ready to come out at any time, unpredictably. So you need to make sure that what you're excluding at great cost to your fund is actually more than chance alone. And it's rare for there to be a single sole reason for people to have cured themselves of having migraine attacks from avoiding one thing. So I think trigger management's helpful for some people, but it's unlikely to completely control the underlying genetic predisposition and complex biology of migraine. So I always remind people that whilst it's good to look for a source and to have some control, it really isn't your fault if you can't control your migraine attacks. It isn't your fault that one glass of wine or one stressful day with 1 hour less sleep seem to be one of the many triggers for your migraine attack, because there is a limit to how much you can control life around you. It's useful, it's very helpful for self-management to know these things, but please don't feel any sense of blame if you're trying to control life around you and can't completely get rid of your migraine attacks. But nonetheless, I hope you found this talk really interesting and helpful for your specific condition. Thanks a lot.
All right. Thank you very much for that presentation, Dr. Jenkins. We're going to transition now to some live Q&A. I know there's been a lot of questions coming in. We've got over 800 people who are still here with us. So we will do our best to answer as many questions as we can. And so let's kick off. So Fiona asks, can you take omega-3 tablets, supplements?
Yeah, for sure. So they're in the combination pills, but also separately. They're one of the more expensive supplements. Omega-3. I was thinking coenzyme Q10. Part of it is that you can take the omega-3 tablets. There's a formal protocol for that specific diet that just came out this year. I haven't tried anyone on just omega-3 tablets as such because the study involved the diet.
Grace had a question about, do the symptoms of migraine change as someone approaches menopause, or does it get worse?
Yeah. So there's some nice, elegant articles about the development through a female's life, and there's these 10 stages of hormones, and they do often get worse for years around the perimenopause, and they often don't improve until the late menopause, which is about the 5th stage in that time. So it can be years of worsened migraine. I always look at it as bookended, where they can have some showstoppers in adolescence heralding the onset where the ovarian activity of estrogen is fluctuating, but then really, unfortunately, years being worse around the perimenopause. So there are sort of hormonal therapies that can be considered, or overall general prophylaxis to decrease the frequency and severity. But certainly, I think hormones are a really important trigger, and it's really quite a common trigger in a migraine population.
Pravita was asking about exercise and said that, is there any suggested exercises for people that have vestibular migraine? Maybe you could just explain what that is for people that aren't familiar.
Yeah, so vestibular migraine is sort of migraine plus. The vestibular vertigo symptoms are analogous to an aura, like a neurological symptom where you might have a visual disturbance more commonly, or you might have sensory or weakness changes heralding the headache. But in vestibular migraine, it can be a bit all over the place and longer neurological symptoms that are as debilitating as the actual headache. It's a very complex area that's not been well studied, but in general, we use exactly the same approaches in vestibular migraine as we do for other migraine, and all the review articles have suggested that that's the most correct way of treating it, whilst our knowledge is that it looks like other migraine, but with these additional and quite horrible clinical features. So I'd be recommending, when you can, to do any exercise. And so, like I was saying, for some people that's only gentle exercise, but it's still something that's still moving. For other people, they can actually push through and do more intense exercise, which is probably more highly evidence-based. So, but even a bit of yoga and those sorts of things is really important when you can.
Connie wanted to know, what is triptan overuse?
Yeah, so medication overuse is defined according to the class of medication being overused. It's a terrible term that needs to probably change because most people are underusing the medication compared to how many attacks they're having. But basically, life is unfair, and if you have too many migraine attacks, you end up taking too many of your acute rescue medications. So for simple analgesics like paracetamol, non-steroidal anti-inflammatories, it's set at 15 days a month being too much, and that doesn't usually worry me too much. But triptan use can spark off more migraine attacks. We used to think it was a rebound phenomenon, but it's a bit more complex than that, probably out of the scope for tonight's talk. But certainly more than 9 days, so 10 days a month or more of your triptan medications over months, it's usually defined as 3 months of overuse, can cause more migraine attacks than you started with. So the typical cycle is someone thinks, it's a genius, better treatment, they get some relief, and then months later, 3, 6, 9 months later, they're worse than they were to start with. And if you ask the history, you realise they're taking these acute medications all the time, and really we need to decrease the migraine attacks overall to allow them to get on top of it with a manageable amount with less onsets and be back in control.
Eliza had a question about ergotamine and whether you could take ergotamine plus caffeine preparation, and can those be bought here in Australia?
Yeah, so Ergot is the typical, is Ergodril. There's a few brands, and the compounding pharmacies in Australia all know what those constituents were and how to make them. They usually make big bottles, like 50 at a time. It's a relatively dirty drug compared to the newer triptan medications, and it doesn't mix with the triptan. So it's really important to not have the ergotamine and the triptan within 48 hours of each other if you're trying them out. But some people can't tolerate triptans for various reasons. And some people find the peppiness of the caffeine with ergotamine is a bit better for them. So as long as it's kept within safe uses, which is restricted up to 10 tablets a week, which is still a lot, you can use them and get them through the compounding pharmacy, but usually with guidance of a specialist doctor, because they do have some side effects. I've seen some people with long-standing cardiac effects from overuse of them, which of course you wouldn't get to with that safer amount, hopefully.
Carly wanted to know about whether there's any specific vitamin supplement regimes or programs for familial hemiplegic migraine.
Oh, that's so interesting, that area. There's a lot of different channelopathies. So more often we're blocking things like the calcium channels or the potassium channel, and that's more a medication-based choice. And there's genetic screening tests, but without any Medicare rebate, they still are quite expensive, almost $600 to do the panel of the 5 most common genes involved in hemiplegic migraine. But only just this week, one of my patients has a B group abnormality that's been rarely described, and but hasn't had a remarkable response really to the B group supplements. So it's just something I'd try for everyone, from normal episodic migraine through to the more chronic types, through to ones with aura, through to vestibular migraine. I would generally suggest people try supplementation as long as they tolerate it for 6 months. And if it hasn't made a spectacular change in the frequency and severity, that's a useful trial. Because it's simple, it's easy, it's cheap. As long as you don't get diarrhea, nausea, or you mind your wee going orange, it's, very manageable.
Ria wanted to know if magnesium's safe to take or if it can trigger depression.
Magnesium is considered one of the safer treatments. I haven't seen it trigger depression in the 1,000-odd patients I've used it in, but certainly depression's a really common comorbidity with migraine, with that bidirectional relationship, and really important to manage alongside the migraine. So in a patient with depression, I'd confidently suggest and use magnesium, and I'm unaware of anything in the literature suggesting it worsens depression.
Helen wanted to know if there's a connection between IBS and migraine.
Oh, yeah. So I assume by IBS, we're talking about irritable bowel syndrome rather than inflammatory bowel syndrome. So unfortunately, migraine is comorbid with, which comorbid means it comes at the same time as other conditions. So genetically, it's quite close to epilepsy genes. So there are very rare people that have both of those. Less understood are the less understood conditions of fibromyalgia, chronic pain syndrome, but also irritable bowel syndrome. And of course, when we've all got a migraine attack, you're aware of that snackish behaviour, altered bowel habit, altered micturition or weeing. Sorry, I'm talking doctor talk, but altered going to the bathroom. And that's all tied in with the autonomic nervous system. So it's no surprise to me that you get more gut symptoms in someone with out of control migraine. And some people feel that that's linked, but it's like the premonitory symptoms is probably more part of the migraine attack. But I definitely have a lot of patients that have disproportionate gut symptoms that don't parallel the improvements and worsening of their migraine attack. So it is definitely something that is tied in for some people as two conditions. Luckily, the diets are similar.
Mox has a question about whether the triggers you mentioned in your presentation also apply to vestibular migraine.
Yeah, I would be thinking about anything that applies to general migraine and seeing whether it helps. Vestibular migraine is interesting because it's often a bit of an acquired thing. You don't see generally, it rarely happens, but you don't usually see a 15-year-old with vestibular migraine. You see them with episodic migraine, treatable with simple analgesics, and it sort of gets these different layers as a person, and you look like a dietary trigger person. It's worth knowing about all these things so you can figure out what affects you individually rather than your best friend's friend saying you've got to try this because it worked for me, because it is really individual what works for everyone. And I think there's the same gamut of options for vestibular migraine as usual migraine.
Renata had a treatment question about NDEP or amitriptyline and wanted to know whether it was due to the improvement of sleep or actually does it help directly with migraine?
Yeah, it's not a bad thing, the improvement in sleep. we certainly use that as a bit of a tool. We know that if we improve someone's mood, we'll help their migraine usually if life is fair, and same with sleep. Sleep is the devil if you're an insomniac. So having regular routine really helps. No, it definitely independently also helps as a migraine preventive. It's not one of the stronger ones. Sometimes, unfortunately, we might get a 30% reduction in migraine frequency and severity, whereas really we'd like a 70% reduction. But these things haven't gone head to head. So it's a good place to start because it's a once-a-day tablet and it has this positive benefit of the worst thing being helping the sleep at night, as long as they're not tired the next morning, because some people don't tolerate that. So we do like it because of its worst side effect of improving the sleep.
Sleep seems like one of those things that just comes up time and time again regarding brain health and migraine. And if migraine is a type of brain malfunction, it makes sense that getting more sleep can help.
There's so many neurotransmitters tied in with our circadian day and night routine, and there's so much science and research going into this. Unfortunately, fixing it with melatonin or amitriptyline NDEP doesn't fix the whole thing, so it's part of the story. But I feel exactly like you, Carl. I feel like every talk ends up talking about sleep. So I feel like there's a lot to do with it, but I'm not quite sure what the answer is yet.
Yeah, I mean, you look in sort of, just from the community, people talk about it as the only way they can recover from a migraine attack sometimes, and other times it's the cause of the migraine attack because they didn't get enough or they had too much. Or
you don't want to oversleep instead of underlet sleep. My bottom line is it teaches you to be as sensible as a 90-year-old or neurologist, whichever you think is the most boring, because it doesn't like change. So you learn to have a very good lifestyle. Breaking press news is from the International Headache Congress last week, I hadn't managed to tell you about. People with migraine have less admissions and death from COVID in the European big data. And so they had this whole talk about how having migraine as an acquired disease is potentially a positive evolutionary benefit. I'm sure everyone who's dialing in today doesn't feel like that when they have a migraine attack, but there are some positive things to having this hyperactive pain thing that tells you when you're not being sensible, because we're not having chaotic lifestyles, because we just can't get away with it unless we have less frequent, less severe migraine attacks. So that's one way I sugarcoat it. But yeah, I think trigger management helps some people.
And we're going to be talking about COVID and the vaccines and on Wednesday night with Dr. Tissa Rijaratney. So for those people that are interested in that area, make sure you tune in same time on Wednesday night. So going back to the questions, Emma wanted to know whether it's possible to have migraine and other types of headache, like a tension type headache as well.
It is. Chronic migraine is defined these days as 15 days of headache, of which 8 are migrainous, and the others can be, literally in their definition, tension type headaches. So I get a bit upset when people come in with mainly tension type headaches but a few migraine attacks from the other doctors, because really we're missing the opportunity to recognise that these are migrainous, and because of the frequency, some of them seem bland. But really, we have the opportunity to use all the chronic migraine and other migraine therapies and reduce them without just saying, it's tension type headache, why don't you exercise? Because really these people usually can't. There's usually, if you dig, the tension type headaches are just lower grade versions, and we learn to call only the showstoppers that stop us completely a migraine, when really anything with sensitivity to light or noise or preference to rest or inability to do all activities that day or nausea are migrainous when it's combined with migraine. So the migraine sort of trumps the tension type headache if there's a mixed bag for me, and there's very few of my patients where they do remain with a tension type headache as well, separate to the, not paralleling the improvement in the migraine. And some people are unlucky enough to have migraine and cluster headache, migraine cluster and hemicrania, continua. I've seen it all. So headachy people get more other headaches. They get more exertional, weird, unusual, rare headache disorders at other stages of their lives. They get more RCVS, totally different headache syndrome. So, you can have several headache types at once, but usually it's actually the chronic migraine just changing as it shifts into a more frequent frequency.
Andrew had a question about what therapies you could suggest for his 10-year-old daughter.
Oh, that's tricky. I'm an adult neurologist. Usually we start, the royal we, because I don't see children, but usually I would think that they'd start with the vitamin supplements. So the B group vitamins, really important. Magnesium, if they tolerate it without diarrhea or gut upset. Then they often use the things with better known safety, whether that's propranolol. So we're talking about medications now. The sad thing about children, when you know that, mum or dad have it and it might be a genetic thing, is they often get treated as if they are anxious and trying to avoid activities, when really the sign that they get this after exercise and they can't exercise as much as they want or participate as much socially or at school, and they're lying their head on their desk like they've got a bad attitude. It's not usually anxiety. It's usually anxiety because they've got a cracking headache. And it's often bilateral, not as migrainous, not as one side, not as clear cut. I have the easy job because they come to me when they're adults and it's a unilateral throbbing headache some of the time that makes us differentiate it. But when they're kids, it's often a bilateral tension type headache, but you look out for that not being able to do all activities again. And I think most general pediatricians are good at getting on the right track. So it's worth talking to the doctor about the best treatment.
And maybe the school and school nurse, so they know that.
Absolutely. Early treatment helps, but they often don't need such strong things. They don't usually need a triptan, those things. And the worst thing about pediatric headache is most of our best therapies have not been tested in the pediatric or adolescent group. And so they're not authorised on our TGA, which is our safety group, to be used in kids. So there's a lot of discrimination. I see these 17-and-a-half-year-olds trying to sit the HSC and they're not allowed to have Botox, which is an entirely safe treatment. We know from the fact that kids use megadoses of this in cerebral palsy and other conditions. So it's a little sad, but if you do get the right doctor and they're not responding to the usual things, you can get special access by requesting authority. But yeah, I don't see kids, so it'll be really a pediatric neurologist that would answer that better in more detail.
They'll probably talk about things like biofeedback and maybe cognitive behavioral therapy, stuff like that.
Yeah, that's exactly right. So, and, relaxation techniques of any sort. I think the kids are so resilient and can learn a lot of things. So we should apply what we know for adults to them as well.
Yeah, absolutely.
Acupuncture is used as well.
What would you say to someone like Anna who gets a migraine triggered by smells? How do you manage that trigger?
Oh, yeah, it's so tricky, isn't it? I mean, we're all managing it by hiding in our houses at the moment, and being the masters of our own clean or not clean houses, as the case may be in my case. I think, you have to have a not aggressive way of just discussing this to people. So I have girlfriends who very clearly tell me they don't like perfume or cleaning product when we sit outside. So without any sense of judgment, you have to sort of educate the world around you that this is not a choice, this is a biological disorder, and you do have clear triggers, and that if you sit there with that chemical smell any longer, you're going to have a migraine. So at different times, if they've painted the rooms that I work in, whatever, I've sat in the courtyard with patients that are sensitive to chemical smells, and thankfully everyone isn't, but some people are. I've had a physio change her hospital job because of the chemicals they used, and they refused to change the cleaning product. So I think be good to yourself, know clearly what your triggers are and avoid them. Avoidance is the swear word in psychology of migraine, but I think when it's a clear-cut trigger, it's actually helpful for individuals for those few things that they have to limit.
I've heard of some people having a candle next to their desk or in their workspace that there's a pleasant smell, maybe lavender. And I've heard of like peppermint sort of oil.
Oh, yeah.
Like there's little hacks sometimes that are helpful, sometimes they're not. But
yeah,
a lot of people have that challenge, I think.
It is. It's really challenging. And I think the challenge has been this huge shift and swings in what we're exposed to and how much control we've got over it now in our own home work environment. I mean, most people are glued to their desk and homeschooling children and, what's for dinner, mum, at a time when life is not easy. So it's not all great for people. But at the same time, the one bit of feedback we've had is that people are more in control of their environmental triggers. And hopefully we learn from that and we take that back to the workplace and in a positive way ask for some changes for that individual. Just like people with a bad back would get a different desk chair. We deserve to have proper treatment so that you can be as productive as possible. It's a good thing for workplaces to not be triggering you off. So they'll generally be quite open, I think, to these suggestions.
Yeah, they're likely to make reasonable accommodations.
Yeah, reasonable, yeah.
Michelle wanted to know, how do I find out what type of migraine I have?
I guess, it's doctors that get all the power, isn't it, to diagnose it. Really, we classify it into with or without aura. So aura is a 20-minute or so neurological episode before the headache. And then we very arbitrarily split it into episodic, which is occasional, less than 15 days a month, and chronic. But there's a tendency now to talk about low frequency episodic and high frequency episodic, because we know that they're just as disabled beyond 9 days a month of headache, as well as being at risk of medication overuse and the things we've talked about. So, we also split that up with that. And then there's the weird and wonderfuls. There's vestibular and hemiplegic and other disorders of more complex neurology associated with the headache attack. So most people will have migraine with or without aura, and that's a good starting point, because if you're in Australia and you're not getting told it's just a tension headache, go and relax, and you're getting better attention and care and consideration that it's migraine, then you're on the right path, I think, to most of the treatment options.
I actually wanted to know if migraine is linked to endometriosis or POTS.
Yeah, it is. They're things that I didn't mention before. So if you've got endometriosis, you have a couple of risks: iron deficiency from the bleeding, which worsens migraine or any headache; prostaglandin-mediated sensitivity of the sensitization of the brain. So the period pain type medications can help at those times. And there's definitely a link to the point that we're talking about it at our scientific meeting this year. POTS is, for people that are not aware of it, postural orthostatic tachycardia syndrome. It's relatively newly described, like as in 5 years or so ago. Some of the cardiologists believe in it, some of them don't believe in it. Not very helpful whether we believe in it or not. It happens that some people get tachycardia changing from their baseline, lying down, to more than 30 beats higher just by standing up. And sometimes it's not immediately on standing, sometimes it's within 5 minutes. So I take a bit of time to check for that, particularly if I've got someone who's hypermobile and other features of that. And it can cause chronic fatigue and postural symptoms that are triggering off, again, bidirectional, triggering off the migraine's triggering it off, autonomic nervous systems all tied in. Chicken and egg is very hard to divide, but certainly if you don't treat the person as a whole, entire person with all these things going on, you don't do as well. So if you recognise POTS, then trying to support that by a beta blocker or fludrocortisone, very different treatments can be really helpful. And like being a new condition, it's very hard to have therapists involved. So sometimes even my patients have done telehealth to Melbourne, where it's good to hear all the Melbourne people there. They'll go, oh yeah, POTS is a thing down here. They've got really good clinicians down there looking after POTS more than in other centres. So I think keep putting your hand up and saying, I think I have this. And if the person looks at you blankly going, POTS, I've never heard of such a thing, you're probably asking the wrong doctor.
So we had two people, Alison and Vicky, both ask about migraine during sleep. And
yeah.
Alison will have a migraine when she's in the middle of the night when she's asleep. How does something trigger that when you're just in bed sleeping? And Vicky says that she has migraine. She wakes up with the migraine either after the migraine or during the worst of it.
Yeah.
What's going on there, and what can they do about it?
So migraine that you wake up with during sleep is often more severe, more noticeable, worse, because it's been playing with you while you're sleeping and getting to that severe stage that's unmanageable. So sometimes you're just noticing it as a worse one because they are worse and harder to treat. But very early on in my interest in headache, I sort of came up with a Jenkins 6 rule. There's usually something going on. If you've got 1/3 of the time sleeping and 2/3 of your migraine or more are overnight, then I look very carefully for a sleep disorder like insomnia, sleep apnea, grinding the teeth, a terrible neck that's getting stiff or sore in the one position while you're busy sleeping, grinding the teeth, high blood pressure, because you get little blips of high blood pressure at night at 3 a.m. or so. That's why people have wake-up strokes as well. Or not that, don't want to alarm you about strokes, but or withdrawal from something. Medication overuse will sort of start to have the head screaming out for that medication that they've upregulated the receptors and now they're empty and starving and they need it more than you need breakfast. Or caffeine withdrawal, same thing, very dose dependent. More than 100 milligrams of caffeine a day definitely is a problem, and probably less than that for migraine, people living with migraine. So they're the ones I look for overnight. Simple. Done. So some people I don't find anything, but it's quite often neck, so sensible boring, low, firm pillow, firm mattress, physiotherapy are things to consider if there's none of those other obvious things. And I think we discriminate. We think of stocky, overweight, older men having sleep apnea only, but if the person's snoring and stopping their breathing overnight and waking up with a startle with arousals, we need to test young women for sleep apnea as well.
Fantastic. Well, Dr. Jenkins, it's been a wonderful, another wonderful presentation from you, and thank you for being so generous with your time and staying on to answer Q&A from the audience. I hope everyone watching got something out of today. Tomorrow, we're going to be talking about preventive new treatments that are available for migraine. So if you were listening before about triptan or medication overuse, that's where the preventives have come in. So hopefully you'll enjoy that presentation with Dr. Stark, who's the current president of the Australian New Zealand Headache Society. But for right now, we'll say good night. Thank you for your time, and hopefully see you all again tomorrow. Thank you, Dr. Jenkins.
Thanks for running these, Carl. They're so important. Thanks.